What today is all about, we would like to trigger a dialogue and to have a step further in the understanding of the social services and their role when it comes to the impact of Alzheimer, because this is not only because of the demography of Europe, but also worldwide. This will be a topic which will become a bigger and a bigger topic for discussion within the social and the health sector. So for us, it's really important that we are part of this conversation and that we're all on the same page when it comes to the impact of Alzheimer. We also have today with us the coordinator of Co-Care, which is a project funded by the European Commission under the Erasmus Plus Alliance program. And we will have Anna with us, the moderator, and she will also share some of the outcomes and the trends that are visible within the Co-Care initiative. So I hope it will be a very fruitful event for us at the SPD. Is an important topic because we see the trend. We see that this is becoming more and more relevant for the people who work within the social services, and of course also for the families of the people who informally support them when there is an Alzheimer case. So we hope that this is a conversation. It's not the let's say the result, but just the start, the process of what we foresee in this conversation. So welcome everybody, and I would like to give the floor to Anna, who is the coordinator of the Co-Care project, and with a large smile, you're taking the floor, Anna, please.
Thank you, Maya, and hello everyone. Thank you for the welcome remarks. The aim of my speech would be double. First, the first part will be trying to introduce a little bit to give some context in regarding Alzheimer, and then explaining a little bit, as Maya already introduced, the project Co-Care, which is one of many projects going on around Alzheimer. So I'm going to share my screen. Please let me know if you can see the screen.
Yeah, it's visible.
Can you see the presentation? If I pass the presentation, can you see it?
I think that if you enlarge the screen on the bottom of your right corner, it will be visible only the slide that you would like to share, because right now we can see the whole.
Okay.
Yeah.
So I thought I was sharing the presentation format, not the. Sorry for that.
Don't worry, Anna. It's been so many Zooms, and I think that people are learning new things every day. So, and we have the patience for it, don't worry.
So this should be. Now, can you see the shared screen?
We see the shared screen. We see the whole presentation, but I'm not sure it's a problem. Maybe we can just go like that.
Okay. So the introduction part will give us some numbers on how is the context of Alzheimer. As everybody knows, Europe's population is growing older. That's a fact. And more than 1/5 of European population was age 65 or over in 2020. This represents an increase of 3% compared to 2010. Life expectancy is also increasing in Europe from an average of almost 78 years for someone born in 2002 and to 21 years for someone born in 2019. So that's the map of the present, and regarding the future, we're going to see in a minute. As one of the primary risk factors for dementia is age, the continued increase in life expectancy and population aging also increases the likelihood of people developing this condition. So that's one thing that we need to consider. And it's necessary to know better numbers about how this prevalence is and will be in the future. And it's essential for research, especially for health and social policy making. But it's difficult to find and to really have a traceable, let's say, data in order to give us realistic numbers on what are the situation and what it will be. The number of people living with dementia in European Union, the 27 European Union, is estimated to be almost 8 million in 2019. And women continue to be disproportionately affected by dementia, with 6 million of women and 3 million men living with dementia in Europe in this date. And the numbers of people with dementia in Europe will almost double by 2050, increasing to 14 million in the European Union and 18 million in the wider European region. So that's the numbers, which are, as you can see, huge. If we look at the tendency, the prevalence of dementia for 2018 by age groups, the more the age increases, you can see here the different lines, they also increase, especially the female line, which is the green one. And if we see this same context by country, the percentage of population in 2018 or the expected population in 2050, here you can also see first the difference between the blue and the green, which is huge, and also the distribution within the countries. Here it's organized by the percentage of population in 2018. With this scenario, we, as a group of partners, which I will present in a minute, started to think about what can we do, especially regarding the, as Maya mentioned, the people around the one having Alzheimer or dementia, sorry for that. And we built, or we proposed a project which is called Co-Care ICT Solutions for Alzheimer Informal Caregiving. And our main, let's say, points of attack.
Anna, sorry to interrupt you. We are not able to see the changes in the slides. Yep. Sorry to interrupt.
Sorry, I thought everything was okay. So now are you seeing another slide different from the one it was in the beginning?
Yes, yes.
So I will try to go back at least for the graphs for you to see, not the text, which is not interesting at all, but the text slides, I already said the numbers and expectations. Here you can see the prevalence of dementia, which I was explaining about the age groups and the tendency with the lines. Here you can see the green line for females, and you can see how it's going up. And then here, the slide I was saying regarding the country distribution. The blue line, it's the percentage of population in 2018, and the green line, it's the expected percentage of population for 2050. Here you can see the distribution of countries. That was a little bit of the context. The other things I said was only written in the slide, so it's not interesting to go back there. And I started to explain about the project, as I was saying, which is the co-created ICT solutions for Alzheimer informal caregiving. The context was, as you have seen, there's a need to propose solutions for everyone around Alzheimer, but we were thinking especially about caregivers. And we also were especially thinking about technology. I think we all valued the use of technology during pandemics, but obviously this technology will stay with us. So we need to take advantage on technology solutions in order to give input on new solutions for caregiving in this case. What we wanted to attack was the way solutions were created. So we are trying to implement and to encourage co-creation for these solutions. So we want to include caregivers and also as much as possible persons with Alzheimer in the co-creation process of these solutions. Then also the learnings that we are trying to do with the project, that they need to be implemented in a teaching arena. As Maya said, it's an Erasmus Plus project, and I don't know if you know the calls, but these specific calls expect an impact on universities, so in the institutions, and on the learning on students. So we are trying to encourage this co-creation within classrooms, in health students, and in technology students, and also foster entrepreneurship in these two arenas working together. The aim is to improve or to have better care solutions, which includes the view of the person who the solution is directed to. Then regarding the partners, as you can see here, there are participating 4 different countries, and 3 of these countries includes a higher education institution, includes a technology company, and includes an association around Alzheimer. In the case of the coordinator, which is us, here you have as University of Vic, which is in Spain, then Fundació Pasqual Maragall, which is an association around Alzheimer here in Spain, and then also Confluencia, which is a tech company working on health solutions. Then we have in Portugal the same structure, which is Instituto Politécnico de Setúbal, which is the university. Then we have also Alzheimer Portugal, which obviously is around Alzheimer, and then KnowledgeBits, which is the company, and the same in the UK, which is University of Derby, the Market Improvement, which is the tech company, and then Alzheimer Society, which is the one from around Alzheimer. And then also we would like to include an umbrella partners, which have like, let's say, an open view on all needs in different countries and makes this European added value, which is the ASPD, which you all know. Then we would like we see that there's a need for new solutions, especially for caregivers of persons with Alzheimer and dementia. That's why we started the project, and we need to better improve the design of these solutions. That's why one of the things we wanted to do was to improve the learning of students, because we saw the lack of collaboration between these different sectors, which is the health and technology sector together, and also giving in the middle of both the university, which can push a little bit this connection between the sectors. The main outputs that we some of them are already done and some of them are under work. The first one is a mapping report about what kind of technologies already exist for caregivers of persons with Alzheimer and dementia, and how are they designed. We have seen that not many includes the participation of caregivers and or persons with Alzheimer. That's good news for the project, not for the society. Let's say we need more participation with the final actors. Then a training course that we piloted this year, where we include the students were from technology, from health students, and also we included here caregivers, which play a role of students, and they co-create together different solutions with the first study the needs that they have and how the quality of life can be improved, and then students work together with caregivers to design a prototype. Then we are trying to build a toolkit for informal caregivers, which try to equip them of what kind of solutions exist and what new solutions will exist in technology terms for them. And finally, once everything is more or less done, an online community of practice where we would like to bring together technology sector, healthcare sector, and also final users, which are the caregivers in this case. And that's a little bit like very quickly explained the project that we are trying to finish by this year. So that's everything from my side. We have the questions at the end, if I'm sorry, here. We have the questions at the end. So now we will see different views around Alzheimer, and I would like to give the floor to Jean-Georges, I hope my pronunciation is okay, which is the Alzheimer Europe's Executive Director, and he's going to explain us a little bit about its campaign to make dementia an EU policy priority. So Jean-Georges, the floor is yours.
So first of all, unmute myself, and then I'll try and share my presentation as well. And let's see whether that works. I think you can see the first slide.
Yes.
And also if I change them, that works as well. That's always a good start. So thanks again to EASPD for the invitation for this Knowledge Cafe, and also very many thanks to Maya and Anna for the introduction. So what I'm hoping to be able to do in the next 7 to 8 minutes is really give you a bit of an overview of Alzheimer Europe and the campaign that we have been running over the past years to make dementia a European priority, and also maybe highlight some of the kind of key achievements that we believe we have been able to achieve at both the European and national level. So Alzheimer Europe is a bit of a similar organization like yours. It's an umbrella organization where we have a number of national representatives. Anna, in her presentation, already referred, for example, to the Alzheimer Society in the UK or Alzheimer Portugal in Portugal. And both of these organizations would be the national representatives in our organizations. Currently, we have 37 national organizations from 33 European countries. And as you can see from that map, we unfortunately don't cover all of the European Union because we are still looking for members in Latvia and Lithuania, but we also have a number of member organizations outside of the European Union, such as the UK, Norway, Iceland, Switzerland, Turkey, Israel, and a number of other European countries. And all of these organizations are typically the national Alzheimer's organizations, which are the organizations that represent both carers and people living with the condition. The strategic objectives of our organization, we actually have 6 strategic objectives in our new strategic plan. The first one is, of course, to make sure that we provide a voice to the people that we represent, which are people with dementia and their carers. And the next speaker from our side would be Chris Roberts, and he's the chairperson of our European Working Group of people with dementia. So you will hear from him the kind of participation and contributions that they give to our organization. Our second objective is making dementia a European priority, and it's really on that topic which I will be focusing on. But we also want to change the perceptions around the disease, and we want to combat the stigma that is still attached in a number of countries to Alzheimer's disease and other types of dementia. We also want to raise awareness of brain health and the opportunities for prevention. And then, of course, as an organization representing a very diverse network of national organizations, we want to make sure that the European dementia movement is as strong as possible. And last but not least, we also would like to support dementia research. And we're, of course, also very interested in the kind of projects that Anna just represented. So if you want us to share information about that project and disseminate that, we will be more than happy to do so. This is a slide that actually repeats a bit what Anna has already mentioned in her introduction, which is why do we believe that dementia should be recognized as a European priority, is of course the overwhelming numbers of Europeans that are currently living with dementia. The focus that I have here in this kind of slides is actually the same report, because it's, I think the figures that Anna was representing are coming from our Dementia in Europe yearbook. She mentioned how the numbers of Europeans would increase for the European Union. Here are the figures for the kind of wider Europe. So in 2019, we estimated that these numbers were around 9.7 million Europeans living with dementia, which by 2025 would go up to almost 4 million. And by 2050, unless we find better ways of preventing and treating the disease, we would estimate that 18.8 million Europeans at that stage would be living with dementia. And of course, also all of these numbers come with costs. And another project that we were involved in was the Eurocode project, and they estimated that by 2030, dementia would cost the European Union 250 billion euro. And I think it's also very important to mention that age is, of course, the biggest risk factor for people developing dementia, but also dementia is currently the leading cause of disability and also dependency in older European adults. And of course, you as service providers will, of course, be very much aware of both that challenge and these numbers. This has been a campaign also that we have been running for a number of years. We started really in 2006 when we adopted the Paris Declaration, which was really where we called for the first time on both national and European policymakers to prioritize dementia across health, social policy, and research agendas. And this was followed up in 2014 by the Glasgow Declaration, where again, we really called for the prioritization of dementia as a public health priority. We called for a European dementia strategy, but also we really wanted to push for a rights-based approach, which should be in line with the principles enshrined in the United Nations Convention for the Rights of People with Disabilities. In addition to that, we've also trying to increase the knowledge about the disease. So we annually produce yearbooks, and for example, one of the yearbooks was in 2019, which was around the prevalence of dementia, which is quoted by a number of people when they are discussing the numbers of people living with the condition. Last year, we looked at dementia-friendly initiatives, and that report will be coming out later this month. We also, on an annual basis, dedicated the topic to ethics. So we looked at a number of issues such as legal capacity, decision-making, diversity and inclusivity in research. And last year, we looked at sex, gender, and sexuality in dementia. And you will also hear from Diane Gove, who is the Director of Projects for Alzheimer Europe, but also really involved in all of the work on ethics and has really been spearheading some of the work that we've done. And she will be presenting some of the kind of thoughts that we have when it comes to the ethical principles linked to dementia being recognized, both other dementia, but also the kind of ethical challenges that some of you may be facing when providing services to people living with dementia. We are also very actively engaged with a number of policymakers. So we've set up within the European Parliament the European Alzheimer's Alliance, where we have close to I think it's almost 200 members of the European Parliament that have signed up to and support our work. We also have set up a European group of governmental experts on dementia, which are representatives of national health ministries in most cases, which we are bringing together twice a year so that they can really exchange information and good practices. As an organization, we're also an accredited non-state actor with the World Health Organization and their regional office for Europe. We have consultative status for the Council of Europe, and we're also an accredited patient organization with the European Medicines Agency. So what have been some of the kind of successes that I really believe we've been able to have as an organization? And we called for the development in 2006 of countries adopting national dementia strategies. At that time, the only country that had a beginning of a very modest dementia strategy on Alzheimer's plan was France. But since then, you can see that now we have dementia strategies in a whole range of European countries. You can still see though from that map that it's very often countries more in Northern and Western Europe, and that maybe some of the Eastern European countries are not quite as advanced when it comes to the development of these national dementia strategies. We've also been very lucky that we've had Alzheimer's disease and dementia, which was a focus of a number of EU presidencies of the European Union. And it was really under Nicolas Sarkozy and his 2008 French presidency conference, which was really the start of a lot of European actions and research in the field of Alzheimer's disease. But then as a result, after that, a number of other presidencies also dedicated conferences and conclusions to the topic. But you can also see that the last time that dementia was discussed at a presidency level was in 2016. So that's really an area where we need to make sure that that will happen again also in the future. And then last but not least, we've also had Alzheimer's in a number of European programs. So there's been in the health program 2 EU joint actions that were dedicated to dementia, which was a kind of collaboration between national health ministry officials, but also academics who work together to develop, to first of all, do a mapping exercise of a number of policies at a national level and develop some recommendations that could be followed by other European countries. And then we're also very happy that dementia has been a kind of priority for research funding for the Innovative Medicines Initiative for Horizon 2020, which is the kind of European research program, but also JPND, which is the joint program for neurodegenerative diseases research, which is a collaboration between national funding agencies, and they're also promoting dementia research. So you could almost think that we should be really happy with the kind of achievements, but of course this is a fight that continues, because there's still an awful lot of work that needs to be done, and especially when it comes to the recognition of Alzheimer's disease, for example, as a disability, and the full integration of and recognition of the specific needs of people with cognitive and intellectual disabilities in all European disability programs. So that's something that we will be dedicating our work on in the coming years as well. And for anybody that's interested in our activities, you can also find more information on the website that we launched very recently, which you can see here, which is the www.alzheimer-europe.org. And with that, I'm handing back to Anna, who can then present the other presenters from Alzheimer Europe.
Thank you, Jean-Georges, for your presentation. I think very interesting things to at the end to discuss. But now it's time to introduce a new speaker. Sorry, can you hear me? Yeah, to introduce a new speaker, who is Chris Roberts. Chris Roberts leads the European Working Group with Dementia within Alzheimer Europe, and has himself been diagnosed with Alzheimer's and vascular dementia. He will explain his experience and how the diagnosis has affected him and his family, and how to develop services in an inclusive way. So Chris Roberts, please, the floor is yours.
Thank you very much, Anna. Can everyone hear me all right? Yes, good. Good afternoon, everyone. My name is Chris Roberts, and I'm the current chair of the European Working Group of People with Dementia. The group was launched by Alzheimer's Europe and its member associations back in 2012. It's composed entirely of people living with dementia, and we are nominated by our national Alzheimer's associations and societies. The work we do is to ensure that the activities, projects and meetings of Alzheimer's Europe duly reflect the priorities and views of us living with dementia. We do a lot of work with researchers, we give advice, and we use our own insights to help with research projects as experts by experience, which we do become. Our members actively participate in Alzheimer's Europe's annual conferences. We give presentations and represent the group at other international events and meetings, both in our own countries and internationally. I've spoken personally as far as Australia and even Japan. I was diagnosed firstly with vascular dementia, and then later on, after more scans and testing, I was diagnosed with Alzheimer's too, which most of you know is commonly more known as mixed dementia. But it's a hidden illness, you can't see it. I also have emphysema too, you can't see that either. And I use that to ground people when they say you don't look like you have dementia. Well, I don't look like I have emphysema either. Sorry. But what initially made me concerned to go to my doctor was that my memory was getting bad, which is totally out of character. I had an excellent memory. Word finding was becoming sometimes difficult, and I didn't notice at the time, but we realized afterwards that sorting money and loose change was also becoming a problem. I compensated by paying with notes instead, and always had 4 pockets of loose change, which my children found very attractive, and always helped me empty my pockets. But we thought that this might be all related to my emphysema and my COPD, but the doctor said, no, this is nothing to do with COPD. She had an idea of what it might be, but had to rule out everything else first, which might be a cause. So the testing started. I was eventually referred to our local memory clinic for testing, And that took about 13 months. But I didn't mind how long the testing took because we wanted a correct diagnosis, not a rushed, incorrect one. During this time, we noticed my driving wasn't so good. I was looking down to see where my feet's supposed to be. I was forgetting where the controls were, and I was also getting lost in what should have been familiar places. All these things shouldn't have been happening. It was causing me lots of stress and being very problematic at the time. When driving, I thought we lived in a world where everyone beat the horns at each other, that everyone was becoming full of road rage and frustration. But it turned out most were just beeping the horns at me. My driving was getting terrible. I decided to give up my license, and this actually empowered me because instead of it being taken off me, it was my decision. I was still in control, and this felt positive, especially as I was becoming more and more lost and felt less of a person. We were relieved when first diagnosed. At least now I had a label, and that I wasn't going mad, and it wasn't a brain tumour, which my wife thought it might be. And we left the clinic on diagnosis feeling completely lost and completely alone. We knew nothing about dementia. Why would we? We were also feeling, well, I was feeling guilty about what I was going to put my family through. And that's when depression started too. The depression and dementia moved in unannounced and shared my family with me. We got the family together to discuss the diagnosis, and I even posted it on Facebook to my wife's horror. But I did that so we can educate others, as well as letting my friends know about my diagnosis. And after a diagnosis of dementia, we realized that the whole family also received the diagnosis. It was going to affect everyone around me. So it has to become a team effort. And with any life-changing illness, you have to change one's life. Only then can you embrace, accept it, and live with it. But mainly due to the misconceptions, the myths, and mostly what you see in the media, you're left thinking there is nothing that can be done, that you immediately become in the late stages of dementia. And this is so wrong, and this doesn't help anyone. The main challenges that I face daily, and what makes this disease difficult to handle, is that it also, as I said, comes in hand in hand with depression, guilt, and having to live with a progressive disability, and a disability that no one can see either. You feel like you're being slowly dismantled and becoming a lesser person than you were, which then affects your confidence and can cause anxiety and stress too. So it's not just dementia you're living with. It's a diagnosis and a devastating illness that, as I said, is shared by those all around me. But being positive, as I always try to do, I eventually will have the luxury of forgetting. My family will not have that luxury. They will never forget what dementia has done to them. So I think it affects those around me more than myself. I have problems with my balance, mobility. I can't always see steps and inclines. I don't see same colours on same colours. I don't always recognise friends and family. I can get lost in my own house, which is very stressful. I can't multitask anymore. I can't write. I don't see the letters in my head. I struggle to cross roads. I can't always distinguish which way traffic is going, especially when it's going slowly for some reason. I struggle with reasoning and fact, and I get mixed up with dreams and reality. I've had to learn to trust what people say. When we realised how little, not just ourselves, but most people in general knew about dementia, we decided to spread awareness, to try and talk about dementia and to come out, as it were. It's this lack of understanding that makes people very fearful and afraid. You know, like just that dark space under the bed when you're a child. But shine a light there and it's okay. But first, it's easier not to talk about your diagnosis. The stigma and the misconceptions added with the lack of understanding go a long way to maybe keep you quiet. It's easier sometimes to say nothing and tell nobody and shut yourself away from the world, which a lot of people do. A lot of people feel ashamed and embarrassed and out of ignorance. So was I, so were we. So was my family, and so were some of my friends. But as I said, by coming out, talking about it and having honest conversations really did and do help. Plus, nobody should have the added stress of trying to keep a secret. Why should you? You can live with it. You can live with dementia. I don't like the phrase living well. Who lives well anyway? But you can live with it. With good information and support, but also with understanding and acceptance too. We have to realise that people living with dementia are still people. And people who become experts by experience in their own right. We still have feelings, we still have rights, and we want to live as normally as possible for as long as we can. People are quite good when they know about my dementia, and are mostly very supportive. But more education, more awareness is still needed. A lot of people still don't understand what dementia is. Services must be continually promoted, supported, funded, and adapted to help all those who are affected by dementias. The people who care for us need more information and more training. And this is what needs to happen. It needs to continually adapt and support us. I hope that goes a long way to explain a little bit of how someone with dementia might feel and the problems that they experience. It's not all about memory. Thank you very much.
Thank you, Chris, for sharing your experience. I think it gives us a lot of input to think about. And finally, we have Diane Wolf, who is Alzheimer's Europe Director for Project, and she's going to explain us a little bit about dementia's disability and ethical challenges when caring for supporting people with dementia. So Diane, please, the floor is yours.
Thank you very much. Just find my slides. Is that okay? Yeah, okay. So thank you very much for inviting me to speak today. And just on this slide, you can see that I'm basically going to look at dementia and disability, looking at the ethical challenges for care and support, and then finish with some conclusions and recommendations. Very briefly, dementia is a syndrome. It's usually of chronic or progressive nature, and it leads to a deterioration in cognitive function. As Jean said, it's the 7th leading cause of death amongst all diseases and one of the major causes of disability and dependency amongst older people globally. But it's not a natural part of aging, and dementia results from a variety of diseases and injuries that primarily or secondarily affect the brain, and Alzheimer's dementia is the most common form of dementia. Alzheimer Europe has long recognised that impairments associated with dementia can lead to disability, and I just draw your attention on this slide to the second paragraph, which states, persons with disabilities include those who have long-term physical, mental, intellectual or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. So, and the point is to say that dementia is definitely covered by this definition and counts as a disability. But when we're talking about disability, but what do we actually mean? There are several different models of disability, and the way we understand and explain a phenomenon such as disability affects the things that we do to try and remove the possible hardships associated with it. A certain view and understanding can limit the kinds of responses and actions considered possible. Since the late 1960s, a one-sided medical understanding of disability has been fiercely criticised. It's been argued that it portrays disability in a biased manner and leads to oppressive practices and social arrangements, portraying the disability as residing in the individual and looking for ways to fix that person, so to say. And the social model acknowledges that disability is not merely a matter of biological impairment, and that practices, attitudes, and social arrangements limit people's opportunities in life. But the social model of disability has also been criticised for placing too much emphasis on the environment. So there's been a movement beyond and within the social model towards more relational and human rights approaches, which recognise the need for medical research into care and treatment, but in combination with action to remove social, attitudinal and architectural barriers and provide support and protection for people with dementia if and when needed. And the World Health Organization, commenting on the United Nations Convention, describes disability as neither purely medical nor purely social, but rather as an evolving concept and an interaction, not an attribute of the person. If and when people with dementia experience disability, they should have the same rights as those afforded to other people with disabilities. And this includes the right to expect reasonable accommodations to be made, and it's a matter of equity, not just equality. So reasonable accommodation means necessary and appropriate modification and adjustments, not imposing a disproportionate or undue burden where needed in a particular case, to ensure to persons with disabilities the enjoyment or exercise on an equal basis with others of all human rights and fundamental freedoms. And the World Health Organization also defines equity as the absence of avoidable or remediable differences amongst groups of people, and inequity as being more than a lack of access to equal access to resources or health outcomes, but also difficulty when it comes to inequalities that infringe on fairness and human rights norms. And below you can see this very well-known image. There's numerous versions of it, and I think it's fairly self-explanatory. With regard to the ethical challenges, regarding dementia as a disability may have personal, social, and policy implications, and it also raises certain ethical challenges. The emphasis on human rights in the United Nations Convention is also relevant to the ethical principles of justice and autonomy, and touches directly or indirectly on the principles of non-maleficence and beneficence, so not causing harm and doing what is good for someone. But ethics is at the core of everyday life, and it's linked to doing what is right and fair based on a complex process of reflection, taking into consideration and balancing not only principles and theories, but also values and related concepts such as integrity and respect for privacy, personhood, and dignity, as well as the situation and, most importantly, the people concerned. When considering the ethical implications and challenges of recognizing dementia as a disability and providing appropriate support and care, we need to look at many issues surrounding the personal experience, including the potential emotional and social impact of both impairment and disability, in combination with barriers that people with disabilities continue to face. And so I'm now going to very briefly focus on two key issues, namely the issue of personal identity and the issue of dementia as a hidden disability, which Chris has already just touched on. So thinking about how people with dementia might experience and feel about disability, it's important to emphasize that disability, like dementia, is not a person's sole identity. People have multiple intersecting and overlapping identities. They choose their identities to some extent and belong to a number of communities. They may therefore find that at one point in time and in a particular context, is that okay, the screen? Mine is looking a bit strange. Okay. They identify with disability and that in another they don't. People may also feel differently about disability, depending on their understanding of it and who defines them as having one. And accepting that one has a disability can also have emotional and sometimes a psychological impact on people. Some people may feel embarrassed or fear rejection, devaluation, and stigma. Accepting or being labeled as having a disability may also have an impact on a person's personal story of who they are, the qualities a person displays in encounters with other people, and the beliefs people have about who they are, their qualities, the kinds of lives they lead, etc. Is this blocked or my screen is looking strange? Okay. The statements on this slide reflect completely different perspectives linked to disability. The first emphasizes the issue of choice and labeling. The actual terms used are also important when seeking to promote well-being and to convey respect. So disabled person and persons with disabilities are both commonly used terms, And within the disability movement, the term disabled person is quite common and associated with a political message, namely that people are disabled by society. And this takes the focus off people's impairments and challenges the assumption that people with impairments are a problem. Nevertheless, some people prefer the term people with disabilities because they feel it more clearly emphasizes the person. And behaving ethically towards people would, however, justify asking what they would prefer. And the other two quotes on this slide demonstrate how people can feel very differently about the same term. And some organizations such as DEEP and the Mental Health Foundation have suggested seeing the term disability not as a potentially stigmatizing label, but as a means to an end, a kind of tool that can be used. The disability rights movement is political in the sense that it was about disabled people coming together to fight for a common cause and to bring about changes in their lives. And although discrimination and prejudice still exists, the disability rights movement has been a massive force for change across the world, and disability activism continues to prevail in social policy and political discourses. But people with dementia are not yet always recognized as being part of this movement. At the same time, not everyone with dementia identifies with disability or wants to lobby for change or to be a disability activist. Disability is also a deeply personal thing. And the quote on this slide, which is, I should say, not from a person with disability, the first one, I think expresses the desire to just get on with life, but to have the same opportunities as everyone else. But according to Tom Shakespeare, the goal of disability politics should be to make impairment and disability irrelevant whenever possible, not to seek out and celebrate a separatist notion of disability pride based on an ethnic conception of disability identity. So words do matter, and in the case of disability may affect whether people with dementia across Europe do or do not want to be associated with it, and the meanings that people attach to disability, with potential implications for both public and private internalized stigma. But aside from terminology and official definitions, it's hugely important that the general public, service providers, government officials, and health and social care policy professionals realize that dementia counts as a disability, even if it's not always visible. People with dementia seeking or using disability support sometimes experience hostility, criticism, and judgment, and a lack of understanding from other people. And this issue was raised by some members of the European Working Group of People with Dementia, that's the abbreviation there, who described feelings of guilt, shame, and anger linked to their experience of using or requesting services for people with disabilities. A person sitting in a wheelchair is still a symbol that's widely used for disability, even though less than 10% of people with disabilities use wheelchairs. And the impairments and possible disability associated with dementia are not always obvious. And attempts have been made to raise awareness about invisible impairments and disability. And on this slide, you can see a few examples from among several. And you could say that the wording might need a little bit of attention. It's not perfect, but I think that the messages are clear, and it's something that could be developed and adapted to various situations. The experience of impairment and disability is partly linked to other people's understanding of it. And so that's what we have to try to promote change. Moving on now to the recommendations and conclusions, Alzheimer Europe's discussion paper, Dementia as a Disability, which can be freely downloaded from our website, contains recommendations targeted at different stakeholders, reflecting a broad number of issues which have been discussed. In the context of the personal experience of dementia and disability, I've just highlighted 4 issues coming out of the work which was conducted with people with dementia. First, we need to have a better understanding of the experience of impairment and disability from a wide range of people with dementia, including people from various subgroups, especially underrepresented groups. Second, we need to promote respect for autonomy and ensure that recognizing dementia as a disability is empowering, doesn't result in harm, and is beneficial to people with dementia by respecting individual choice and exercising sensitivity. Third, we need to ensure that people with dementia are not obliged to identify as disabled persons in order to have their human rights upheld or to access care and support. Access to support and care should be based on needs, not classifications of disability. And finally, we need to raise awareness about disability and dementia, not only amongst the general public, but amongst policymakers, service providers, and health and social care professionals. Specific Ethical principles and related concepts dovetail with a rights-based approach, which is clearly framed in terms of disability rather than a disease-specific model, and focuses on rights, equity, empowerment, and inclusion. Alzheimer Europe calls for a progressive and positive change in society's response to dementia based on recognition of potential disability accompanied by a change in attitudes and the provision of coordinated, appropriately funded, and properly monitored policies, services, and support. It's important to learn more about the personal experience of impairment and disability in the context of dementia, to raise awareness and understanding of dementia as a disability, and to do this together with people with dementia. And I'd like to end with an image of Chris Roberts making a formal statement about dementia and disability at the 4th European Parliament of Persons with Disabilities in Brussels, flanked by all the members of the working group of people with dementia and their supporters. Thank you very much.
Thank you, Diane, for the presentation. Now it's turn for questions. A question was going on in chat. Maybe you can do it out loud in order for all people to listen and the question and the answer. I think it was Tom who did the question, or if there's someone else who want to ask something, you can raise your hand and then we will try to organize the questions.
Yes, thank you. Yeah, I mean, the question was in the chat. It's Chris mentioned, and thank you, Chris, for your intervention. You mentioned the importance of getting good support. I was just wondering what good support meant for you, because you know, everyone has an opinion around that.
Yeah, I think it has to be flexible. It shouldn't be based on any assumptions or misconceptions. It has to be based on the person that the support is for. I think that's firstly, that's necessary, because people are so different, different backgrounds, different environments. People are different themselves. It also depends on who, if they live with anyone, if they've got support themselves around them. It has to be very adaptive. And as I said in the chat, people don't know what they don't know. So how are we supposed to ask for something if we don't know what exists out there? You know, so I think that the first bit of support has to be information, and it also has to be stage. Can't remember the word now. Stage appropriate. You know, it's not about age. I've got some very good friends in the 80s and 90s as well as younger friends, but it has to be stage appropriate. No one wants to sit in a peer support group or a room with people who are more advanced, or maybe people who aren't as advanced. So I think it all starts with what matters to me. Thank you.
Thank you, Chris. There's also a raised hand with, I think it's Pep. If you have a question, you can go ahead.
Yes, thank you for the presentation. I think it has been very interesting. And I'm working in the relation between dementia and disability rights for a long time. I've been connected with persons related to Dementia International, Kate Saffer, one expert from Australia, and I remember talking with Care in the framework of the last Congress on guardianship. Fortunately, now I'm from Girona in Catalonia. Now, from the 3rd of September in Catalonia, there is guardianship has been abolished, and nobody can be deprived of their legal capacity due any kind of disability. Supports can be appointed, but always respecting rights, wills, and preferences. My organization has dealt with the old guardianship, and now has been a promoter of this change. But I realized that there is a gap when person has not made no kind of plan about what the person wants if they lose the ability to manage their own affairs. We have a very few use of this kind of legal instruments, and in many cases we have been asked to intervene in critical situations when there is some kind of abuse, undue influence, conflicts between sons or daughters or relatives that has different perspective about how to take care, how to spend money. Money is one of the first ways. And I want to ask all the speakers, what about the development of the safeguarding system to ensure that this legal capacity, universal legal capacity, will not be used by people who can manage soft manipulation skills that at the end are the winners. I'm very worried because in the old system was hard and strong and against human rights, but at the end, when public prosecutors in my region see something not clear, we have a lot of tools to enter in the life of that people and try to manage. Following wills, yes, but many times I have heard, I don't care about my sons stole all my money. I don't care because it's my son. And this kind of safeguarding is not well developed anywhere, and I want to know your opinion on that, because I think these kind of situations can rise and can be more frequent in this aging society.
Thank you, Pep. I think Jean-George had a raised hand, so maybe you can try to answer the questions and then go ahead with your own question if you want.
Because I didn't actually have a question, because I wanted to also follow up on what Chris mentioned. I'm going to try and combine maybe the two questions that were asked, because I think one of the issues that we have is that very often people receive a diagnosis, sometimes at a very late stage, sometimes not at all. But even when they're getting the diagnosis at quite an early stage, what is very often lacking is proper post-diagnostic support. I think one of the things that we did, for example, we did a kind of carer survey where we asked people, what was the type of information that you received at the time of diagnosis? And 1 in 5 people left the doctor's office with nothing but the name of the disease with which they had just been diagnosed, and no other information. And in most cases, they received some information maybe about treatment opportunities, maybe they had some information about the disease and how it might be progressing. But what was almost always lacking was information about services that might be existing, support that might be existing, the regional, local Alzheimer's organization that might be providing help and information. So that was very often missing. And when we're talking about post-diagnostic support, the number one thing that people really need is, rather than them having to identify all the help and support that might be available, but they should have somebody appointed for them that should be able to provide them as a kind of case manager or a care coordinator that can identify what their specific needs are and identify the best services and people that might be able to provide that help. So I think it's very important to have that post-diagnostic support put in place, to have that kind of care coordinator in place. But I also understand what Pep is saying, that very often at that time, it should also be the time where people start thinking, especially in the early stages of the disease, who do they want to involve in the future in decision where they might not be in a position themselves to be the sole decision maker, where they need support or where they need somebody to help. And these kind of advanced directives or living wills or whatever you want to call them, that's something that should also be part of this post-diagnostic support, so that there's some kind of signposting. Who do you trust? Who do you want to involve in these kind of decisions? And very often it comes, as Pep is saying, at a time where there's suddenly a crisis. Nobody's ever discussed this issue in the family. Nobody's thought about these kind of questions. And then when something goes wrong, it is very often too late to then involve the person, because they may be at too advanced a stage to then be fully involved in these kind of decisions on who would be, how do they want, who should be looking after their money, who should be involved in kind of care decisions. But Diane also has done a lot of work around the legal capacity, and she might also be able to input something around this very specific issue. It's a great success to have these kind of strict guardianship systems abolished, because legal capacity should not be a black or white decision. It's not you either have it or you don't, but there should be ways in which you can support somebody in making decisions. But I think Diane also has some ideas about that kind of assisted and supported decision making.
Yeah, thanks, Sean. I mean, I agree with all the points that you were making just there. And also with the issue of the family, I would say that increasingly it shouldn't be possible for any automatic right for members of the family to make decisions on behalf of a person who lacks capacity. And although that, I'm not sure if that still exists in any of the legislation, you maybe know that better, Pep. But I think that certainly shouldn't be an issue. Every attempt should be made to ascertain the person's known wishes, but as you say, there can be cases where they're not known. And as Jean was saying, it's not a black and white issue that somebody has capacity or they don't. But I think also the importance of, even if the person's actual wishes about a particular issue are not known, it may be possible to find out more about their previous wishes through their value statements and the values in life and how they would relate to that decision. But then again, you need to have people who are familiar with the person and trusted, and the actual healthcare professionals can actually trust those people concerned. But then one of the issues that we developed in our ethics work on legal capacity was the importance of supported decision making, but never to actually assume that you can always support somebody to make a decision right through to the very last stage, and that at some point it is necessary. We felt in the positions that we took, it is necessary for some form of substitute decision making, even though there's every possible attempt should be made up until that point through shared and later supported decision making. A very valid point that you raised, though.
Thank you both for answering the questions. We have another hand raised from Tom coming from the floor. Since it's 3:06, maybe we can collect this question and then then we go for the concluding remarks. So Tom, if you want to go ahead.
Yes, thank you, and sorry for coming in again. Right now at ESPD, I'm head of policy at ESPD, and we're working a lot on the EU care strategy. And when we're speaking to people in the European Commission, the Parliament, and others, we're always pushing for the transition away from institutional care to community-based care, home support. And often what we get back from the Commission is yes for people with disabilities, no for frail older people. And when we ask, what do you mean by that? They're saying, for example, people with Alzheimer's, and it's like severe stages of Alzheimer's. So what we often hear is that institutional care settings is okay for people with severe Alzheimer's, and it's not okay for other people with disabilities. And so I would like to know your opinion about this. Are they right? Is there a difference, or are they wrong? And it should be the same discussion around community-based care services. Thank you.
Thank you, Tom. I think it's a tough question to answer, and probably it will have something to do, or we need some contextual explanations on what community or home-based care can be applied in different countries. Probably you have a cultural understanding of what this means and what this implies and what resources you have available. But I don't know if Jean-George,
I think I can make a very quick reaction, which is I think that as an organization, we also feel, of course, that home support and home care should be prioritized over institutional care. But we wouldn't necessarily say that institutional care has to be avoided at all costs and in all circumstances, because number one, I think sometimes people with dementia themselves feel that being cared for in an institutional setting might be a good way for them, because they may not be able to live on their own without additional support. So sometimes it's the wishes of people themselves to get that kind of support in a residential setting. And sometimes also, of course, you are dealing with issues where you may have wishes of the person and wishes of the family, and the possibilities of the family in providing support at home. So we agree that home care should be prioritized, but we wouldn't necessarily say that residential care should never be provided to people with dementia in advanced stages. But I also see that Chris has thoughts on that, and also Diane wants to be involved in this discussion.
Yeah, it also involves cost. You know, cost is something that people can't always afford. But I would like to actually reach a stage where, if I need lots of support, I would like to go into residential. I would like to be supported by people who know what they're doing, you know. But there's just as much stigma about residential and care homes. People are so scared of going into a care home, and yet it could be, as you said, John, the best place for them. If someone's living on their own, they're going to get socialization as well as support, which is absolutely brilliant thing to have. So there's just as much stigma as there is affording these things.
Maybe Diane, you can also add something because you have the hand raised.
Yeah, just to say, I fully agree with John and Chris, and that, you know, it's not an either or, but I think that it really fits in with the issue of disability to a certain extent with regard to reasonable accommodation, that every effort should be made to give people that choice as to whether they want to carry on living in their own homes or to move into residential care, which can, as Chris and John were both saying, can be what the person would actually prefer. But I think that there seems to be some kind of a hint of discrimination to label a group of people as frail older people, and in brackets people with dementia, which is not necessarily the same thing either, and to say but not for that group of people. And I think that's unacceptable. And also I think that we need to look at the structural inequalities, especially because we're just working at the moment on the issue of sex, gender and sexuality, and one of the issues that's coming up there is the kind of disproportionate numbers of older women with dementia in care homes, which is not just solely attributable to the greater numbers of women with dementia than men, but the actual issues in society, which means that women, and it's also especially lesbian and bisexual women, who may end up in residential care, not through choice, but through various issues throughout their lives within society, and structural discrimination against them. That is complex.
But I think we've touched on a really interesting topic that I think as organizations, we should be able to continue discussing. And I think this would be really interesting to have some exchanges, not within this meeting, but maybe offline, and see whether we can develop common positions and recommendations on this topic.
Totally agree. As I said at the beginning of the question after Tom did it, I think it's a complex issue, and also a matter of, Chris pointed out the meaning of being institutionalized for the family, for the person, and you really need to be careful on what you propose, saying this white or black matter issue, which is very, very dangerous. Maybe it's time to conclude. I don't know if Jean-Georges, Chris, Diane, you would like to say like the last word for the meeting today, or add something to conclude? I think
I really thought it was a really interesting first discussion. I really enjoyed this meeting, and I can really see from the kind of questions that there are a whole range of issues where, as organizations, we probably have a very good reason to meet more often. And I've also delighted that we're discussing a potential memorandum of understanding between our two organizations. And I think that we're very looking forward to future collaborations and other meetings, and good contacts between the two organizations.
Great. So thank you all for being here. I don't know if someone from ESPD would like to say something, like to close the event, as they are the organizers. I don't know if Miguel is here or want to say something just to close the
Yeah,
event.
special. Just thank you very much for your participation. It's been really interesting, and I'm sure people will want to continue discussing about this. We went over time, so thank you very much, everybody, for staying with us. Thank you.
Goodbye, everybody.
Bye-bye.
Bye-bye, everybody.
And thank you. Very interesting meeting.
Thanks a lot, everyone.
Bye-bye.
Bye-bye. Bye.